Good morning, good afternoon, good evening, everyone. Thank you for joining us and welcome to the final webinar of our four-part webinar series, More Health for Today's Money. As people continue to join, and I see our participant numbers rising as I speak, let me cover just a couple logistics for the webinar this morning. So we're using Zoom. And we will especially be using the Zoom Q&A box. If you have questions for panelists during the session, please use that Q&A box. If you do not see it immediately, please click on More at the bottom of your screen, and you should see the Q&A box there. Then it will should stay there on your screen. Please also feel free to use the chat box to introduce yourself, share any comments, or if you have any technical difficulties, you can put that there. But please, reminder again to use the Q&A box for any questions for our panelists. We will be answering questions there, and those will be available after the webinar. Okay, so thanks and welcome again, everyone. Good morning, good afternoon. My name is Nathan Blanchette. I'm a program director at Health Systems Insight, and I'm very pleased to kick off today's webinar, which is co-hosted by Health Systems Insight and the Center for Global Development. This is the last in a four-part series organized by HSI's Strategic Purchasing for Primary Healthcare project, which has support from the Gates Foundation. I will share some brief opening remarks today about the series overall and our plan for today, and then we'll move on to our planned discussions. Next slide. So if you've joined us previously, you've seen this slide before, but I want to take a moment to set the context in which this whole series and today's session takes place. And that is a severe tightening of health financing for primary health care. So we know that governments are facing rising fiscal pressures from debt and inflation. Evidence shows that is leading to actual declines in public health spending. We also know there's declining external health financing with projections anywhere between 19 and 33% reductions in future bilateral health aid. Those declines are exacerbated by actually an increase in demands on primary health care that come from growing populations, as always, but also growing levels of chronic disease, pandemic risks, and climate change. Bringing this all together, you can see on the chart on the right some World Bank projections that show clear shortfalls from what is expected to be spent and what would ideally be needed for minimum public health spending for universal health coverage benchmarks, low-income countries on the left, low and middle-income countries on the right. Altogether, I think we can all agree that more money for health would be important, but the focus of this series really is how vital it is to use existing resources as efficiently as possible. Next slide. So with that constrained context in mind, our project, the Strategic Purchasing for Primary Healthcare project, has worked for the past 8 years in 6 countries, and we've taken the last several months to reflect on that experience from Burkina Faso, Indonesia, Kenya, Pakistan, the Philippines, and Uganda, where we've worked with governments and partners to strengthen primary healthcare financing in a number of ways under real-world constraints. Our reflections led us to 4 interlinked priorities that we feel particularly meet the moment of today. We started at the district level, showing how better data on inputs can lead to more strategic resourcing of primary healthcare. We moved on to talk about the importance of coherence across mixed national purchasing programs. In a third webinar, we focused on the flow of funds and how important it is to find efficiencies in that flow of funds and more effective use of funds at the facility level. And that brings us to today's final webinar, which brings the principles of the first 3 together a lot to focus on an extremely important part of primary healthcare, and that is improving the financing for medicines and supplies. And we are going to take advantage today of some fantastic work that has been done by a multi-organization working group on this very topic. And you'll hear more about that working group shortly. Next slide, please. We have much to cover today, so I'm not going to try to vocalize this slide, but if you have missed our prior webinars, please do visit them. Here are some key takeaways from them, and they are all available, both the live recordings plus a lot of related resources to them on our website. My colleague Elaine has put the link to that in the chat, so please feel free to visit these. Next slide. Here's our plans for today. Following my opening, we'll go to an introduction of a conceptual framework that has been created by the working group I mentioned. We'll walk through country case studies of that, and then we will hear from several experts and have an expert panel discussion. Next slide, please. That plan should allow us to achieve 3 objectives today. There's a what objective, and that is the conceptual practical framework that we'd like to share with all of you. There's a so what, which really explores common financing, governance, procurement, and operational challenges across multiple countries. And then we'll move increasingly towards the end, towards the now what, which is about identifying practical priorities, reform opportunities, next steps that we can take together on this important topic. Okay, so with that, it is my great pleasure to hand off moderation and open up for our first presentation to our colleague from the Center for Global Development, Catherine Klemperer. Catherine, over to you.
Thank you very much, Nathan. Next slide, please. So as Nathan mentioned, I'm going to give a little bit of a grounding in what the work that the Center for Global Development has been doing so far in this space. And so we're framing this work around the financing of supply chains and how we're trying to fix this missing link, the link being between the financing communities and the supply chain communities. We think this is a really vital area, especially in the current context of aid transitions and trying to generate more sustainable health systems. But to do that, we really need the buy-in of both fields. So we're trying to fix that missing link. Next slide, please. So a little bit of context. We know that there's fundamentally an access issue. 1 in 4 people can't access the medicines they need, and the number is even higher for people who can't access the diagnostics that they need. And when people can't access these products in the public system, they're forced to go into the private system and then pay out of pocket. And so we have over 1 billion people who spend more than 10% of their family budget on healthcare. And these statistics were from a few years ago, and this situation has now been made worse by aid cuts. So we did a piece looking specifically at the role that US aid had traditionally played, and we found that 9 countries received the equivalent of more than 10% of their domestic health expenditure as US aid for supply chain specifically. So this is a huge gap that's going to need to be filled. And clearly, low and middle income countries are going to need to scale up their domestic financing and procurement. But the issue that we see is that there's a lack of global guidance on how to do this, and there's national policies on health financing rarely consider supply chains. So like I said, there's that missing link. And fundamentally, if supply chains aren't financed properly, people don't get the medicines they need. Next slide, please. So to address this, we at the Center for Global Development have convened a working group on this topic. So we've brought together about 25 experts spanning both the health financing and the supply chain fields, including academics, policymakers, multilaterals, implementers. Health Systems Insight are represented on this working group, and we're spanning 5 continents. So we really want to bring together a community of practice around this so that we can work together to tackle this issue. Next slide, please. So the first thing that we've done as part of this working group is to develop a novel conceptual framework. And this was produced with the Africa Resource Center. And the idea was really to ensure that everyone was speaking the same language, that the health financing experts and the supply chain experts, the domestic policymakers, normative agencies, everyone understood each other when we're coming together to tackle this issue. And hopefully this could then organize the research better. So this has been an iterative process. We published an initial version of this framework back in September of last year, which tried to bring together public financial management, health financing, and supply chains. And then since then, we've been iterating on this through working group deliberations, wider consultations, and case studies, which Anuj will talk about in a moment. So this is a work in progress, and we welcome your feedback on it. But what I'm going to present now, just to ground us all, is where we currently are with the framework. And I should note it's slightly different from what was tested by Anuj et al. Because it built on that work. Next slide, please. So this is the framework as it currently looks like. Uh, as an overview, it's roughly three main phases, moving from the planning, the sourcing, to the delivery, and then two cross-cutting functions, which impact all the other functions within the phases. And it's not meant to be about who is doing the functions, but really what functions need to be carried out so that health financing, financing of supply chains is done effectively and ultimately leads to people receiving the medicines they need. So I'll just briefly run through the parts of the framework, starting on the left-hand side with the governance and public financial management. So this really feeds into all the later stages. It's all about the rules, the institutions, the processes that determine how decisions are made, whether funds can flow effectively, if there's coordination between it. And fundamentally, that impacts the efficacy of all the future functions that we have. Then moving into the main body, we start with the planning, working out what it is that we want to get. The first stage of this is revenue raising and pooling. So bringing together the different streams of money, whether that's from donors, from insurance, from national budgets, bringing it together into one pot for visibility. And then once you have that, you can move to the planning and prioritizing and the budgeting. And these two functions are iterative. So you might plan and prioritize, for example, using health technology assessments, thinking about essential medicines lists, but then depending on the budget, you might have to reprioritize and change what items you're going to procure. And the other part of this phase, is the health product pricing regulation. So many countries might attempt to regulate prices for health products, and that should be informed by market intelligence, thinking about the nature of markets and the number of suppliers, their usual prices, and the value the technology has to the health service. And that really is to then ensure that this next phase, the sourcing, is able to achieve the best value for money. Moving through to that next phase, sourcing. So once you've decided what you want to get, this is really how do you get it? And crucially, we've split this into two routes. So you either have this direct funding of commodities, where you directly have a budget line for the health product you're going to source, and you do the sourcing, which is really about the contracting and seeking out the suppliers. Or you can do it in an indirect way. And so you purchase your products via your health services. And this might be more familiar to people from the health financing domains. But crucially, this means you don't have direct insight on how much of your budget is going into the health products. And we think that lack of visibility is important. But either way, it then moves, you still have to do the sourcing phase. And once you do the sourcing, which is more the operational, strategic contracting, you then move through to the procurement phase. This is normally where money actually changes hands. And then once you've got the products, you have to actually make sure they get to the patients. So the delivery phase. And this includes both storage and distribution. And we think this is an area which is normally quite neglected by experts from health financing fields, but it's actually crucial because if you don't deliver the products to where they need to go, you're not solving the access issue. And so there are questions on how you do that, how many tiers you use, and if there are issues with the money flowing through, how can you resolve that? And then finally, this all through links to access. So I'm trying to stress the point that why we're doing this is because there's an access problem. And we're not saying this is the only thing that you need to do in order to increase access, but this is something that we think is a tangible area that is important and we can fix. And the last point on the right-hand side is this data analytics and intelligence function. Again, this is cross-cutting. There's lots of information from different functions that need to feed back into other functions, feed into how you plan and prioritize. I mentioned the market intelligence needs to feed into health product pricing regulation. But there's also, you need to monitor that if the system as a whole is working and if it is actually helping to increase the access. So that's a quick run through of the framework. Next slide, please. And the idea of this is that it should be a diagnostic tool that countries can use to help identify bottlenecks in the financing of supply chains, to map responsibilities across actors and across levels, and ultimately then to structure and improve global guidance to countries. And like I mentioned, one way that we've been testing if this is working is through country case studies. And that's what Anuj is going to be talking about in a moment. But just before we get there, next slide, please. I just wanted to zoom back out to think a little bit more about the other work that we've been doing as part of this working group. So we're producing 6 background papers. They're sort of roughly working through the issues in the framework that I talked about. So we start with a governance question. When we have duplicative or fragmented streams of financing, what structures and policies and processes can coordinate the planning across the funding sources? We then have a piece looking at public financial management and thinking through the touch points with health financing and supply chains. A piece on decentralization, which we've just in fact published today, and my colleagues will post a link to that in the chat, which really thinks through what functions are most appropriately done at which levels and what are the prerequisites in order for that to be done effectively. Then we looked at pooled procurement. So countries might be losing access to pooled procurement mechanisms given the decreases in donor funding. But what does that actually mean for financing? Like, how do the prices that countries have been using through pooled procurement compare to what they get when they self-procure? And so ultimately, it seeks to answer the question, with the aid volatility, should low and middle income country governments seek to keep access to existing pooled procurement mechanisms or develop new mechanisms? Then thinking about the delivery phase, we see that when there's delayed payments, it can lead to private supply chain actors leaving the market. So is there a tool, an instrument we can use, such as reverse factoring, in order to make those payments more reliable and timely and to solve that problem of actors leaving the market? And last but not least, looking at data integration. So currently you often have health finance data stored in one place and the supply chain data stored in another place, and it might not be interoperable. And we really wanted to think through what is the value of integrating those data sources? Can we use a use case driven approach to integrate where it's really needed? We've also been doing a couple of country case studies. So we looked at the Remediar system in Argentina for essential medicines and how they've been procured separately to the rest of the system. We looked at how concurrent health financing and procurement reforms in Mexico and re-centralization process worked for them, and again, showing the issues between the lack of interaction of these health financing and supply chain procurement fields. And I've included a QR code here, which we can, if you would like to keep up to date and see when these things are published. And this is all being tied together into a final report, which will come out in Q1 of next year, where we'll really pull together the key ideas from all of these papers and propose policy recommendations for governments, for donors, for multilaterals. So that's, like I said, a quick run through of the work that we've been doing on financing of supply chains. And like I said, the first output we did was on the conceptual framework, and we were working with Anuj and Health Systems Insight to really test if that was appropriate. So I'm now going to hand over to Anuj to speak to about that. So Anuj Patnaik is a senior technical advisor at Health Systems Insight. He leads their cross-country work on medicines and health supplies financing, and he's going to talk a little bit about the work he's been doing with us testing this framework. Anuj, over to you.
Great. Thank you, Catherine, and hi, everyone. Pleasure to be here. One of the questions that naturally follows from what Catherine talked about in her intro is whether this conceptual framework really reflects how medicines and health supplies and products are financed in real health systems and all the diversities that are inherent within that. So to answer that, and next slide, we applied the framework across 4 very different LMICs, both to see what it generated and the kind of patterns and challenges that emerged, but also to provide feedback to the working group on the framework itself. And as you can see from the original report and what the framework was and what Catherine presented, that has kind of fed into some changes into how the the framework is put together. So what we did was quickly, we developed a tool using the original framework and applied it across 4 countries. And these are 4 countries within our strategic purchasing for primary healthcare project: Burkina Faso, Indonesia, Kenya, and Pakistan, specifically Punjab province in Pakistan. And we conducted key informant interviews with HSI and SP for PHC country staff that are based in the countries. And they consulted their own stakeholders to kind of fill out the tool, and it was a series of calls. And then all of these countries, we recently had gone through a similar process, putting together these supplies financing fact sheets, which I'll share later, and they're available on our website. Next slide. So over the next few minutes, I'll briefly share what we learned from applying the framework in practice, whether it worked, the common patterns we saw across these countries within the 4 main phases of planning, procurement, delivery, and monitoring that Catherine went through. So the first kind of big takeaway is that it did work pretty well. I mean, there were bugs, there were challenges, but the framework really helped develop a common language across topic areas with experts who often are working a bit more in silos: health financing, public financial management, supply chain experts. They were able to use this one framework pretty easily. There was issues around even definitions of certain terms like purchasing, but we were able to kind of go through that with the tool. The other thing about applying the framework is that it organized and connected health financing, PFM, and supply chain management into one comparable structure and flow. And it allowed for the identification of key bottlenecks across the 10 functions and showed similarities, even across very different contexts, from Indonesia to Burkina Faso, but certainly more so regionally. For example, countries with central medical stores in sub-Saharan Africa versus countries in Southeast Asia with very huge national health insurance schemes. So I think the takeaway from applying the framework is that it built the foundation to now evolve into practical country diagnostic tools. I think that's the next step, to then help governments think about these issues together rather than separately, and improve these systems. Next slide. So getting into the planning, what we found immediately and through the case studies and through the working group is that few countries, if any, actually finance medicines through a single integrated pathway. And this example from Burkina Faso here, which is from our supplies financing fact sheets, illustrates this well. There are often different parallel supplies financing cycles happening at the same time in every country. The first diagram here shows the kind of government budgets and systems that Catherine talked about. Then in Burkina Faso, you have the donors playing a major role in vertical program meds. And then the third diagram here shows the Gratuite program, which covers maternal health and family planning services, and the money that flows through that. And what isn't even represented here in Burkina Faso is revolving drug funds, which play a huge role. So all of these are financing different or sometimes the same medicines through separate mechanisms. And this is similar patterns in the countries we looked at. There's not one integrated supplies financing system. Most countries operate multiple cycles with different rules, timelines, and accountability arrangements. And our speakers from Kenya and the Philippines in this session will dive into that much more. Another key finding just on the planning stage was that countries often invest considerable effort, including from donors, in forecasting and quantifying medicine needs, that often those estimates don't translate directly into budgets. Instead, final allocations are typically made using historical spending or fiscal ceilings, and we'll get into that more in Kenya and the Philippines. Next slide, please. So on the procurement stage, on the left side here, you're going to see the general trends across the 4 countries. On the right side here, you'll see what it looks like in Indonesia, and our colleague Baharimat really helped with this. We found that procurement, and this is something that came out from the conceptual framework as well, is broken down into many separate sub-functions, and these sub-functions naturally sit at different levels of a country's health system. So across all 4 countries, the upstream procurement functions, things like setting the medicines list, supplier qualification, tendering, negotiating prices, contracting, those are almost handled centrally, where countries can leverage purchasing powers and economies of scale. Then as you move down the system, functions become increasingly decentralized. Districts and counties are typically responsible for ordering, warehousing, distribution. Facilities manage inventory and dispensing, and in some countries have greater authority to purchase medicines directly. So I'm not going to go into all the details of Indonesia, but it's a good example of how this works in practice. And in Indonesia, at the national level, you have the MOH, you have the LKPP, which is the National Procurement Agency. They establish the national medicines list, they negotiate framework contracts, and they make suppliers and prices, provincial suppliers, available through the e-catalog. Then the districts place orders through that e-catalog. And at the PHC facility level, PHC facilities in Indonesia called puskesmas, the BLUD puskesmas, which have greater financial autonomy, they can actually order directly on the e-catalog and purchase from alternative suppliers if they're stockouts. Whereas non-BLUD facilities have to go back through the district and there's delays in getting their stocks. So the overall takeaway here isn't that procurement should be centralized or decentralized. Rather, different sub-functions of procurement tend to work best at different levels, provided the financing, governance, and capacity are in place to support them. And Kenya and Philippines actually offer some really interesting examples about that. As Catherine mentioned, more details on this topic can be found in our decentralization paper with Sophie Witter, and we'll share this, I think, during the webinar. Next slide. So the final two phases of delivery and monitoring is next. I'm not going to go into everything here, but on the delivery side, the cases revealed certain hidden costs of delivery, which Catherine mentioned, health financing doesn't always get into, typically. So for example, in Burkina Faso, drugs are delivered to the district, but PHC facilities are responsible and bear the financial burden of figuring out how to pick them up and transport them back to their facilities. So there's hidden costs there that they have to put into budget lines that aren't always, put together in the formal process. On the monitoring side, we realize that there are many, many different data sets floating around most countries, from market intelligence to supply chain to LMIS data to multiple financing data streams, all on different timelines and systems usually. And this information is certainly not integrated, but at the very least, it's not well aligned. So the problem at the point of delivery and the point of decision making is the right information, which may be collected and out there, is not actually getting to the right person at the right time in the right form where they can act on it. The other piece that came out of this section across all of the countries is that many of the issues here were not just technical data issues, but really about governance and who is supposed to do what. So it's not just that they needed more data; it was who has the roles and the responsibilities to take care of things. So again, as Catherine mentioned, there's an upcoming CGD paper from Cheryl Cashin and her team going into this. That's really interesting. Next slide. So I'll finish by highlighting that this work represents a broader learning agenda rather than this single report. Over the past several years, we've developed a suite of products, from this cross-country case study report to country fact sheets with these detailed diagrams with how each cycle works within 7 countries and identifying the key bottlenecks. We have this paper with Sophie Witter on decentralization and other platforms where we've shared some of these ideas. So we're really trying to drill down on how this actually works in countries and where improvements can be made. So I think the next couple presentations from HSI staff in Kenya and the Philippines will get into this in a lot more detail. So with that, let me introduce our next speaker. Eric Morangi is a technical advisor at HSI, where he leads county-level implementation of health financing and UHC reforms across Kenya. He has over 20 years of experience in public financing and health system strengthening, and is going to lead us through some of the key points of his work on this topic in Kenya. So just quickly reminding people, just put your questions in the Q&A section of the Zoom. So you have to click on the More button and click on Q&A. Try not to put in the chat. The chat's just mostly for introductions. Over to you, Eric. Thank you.
Right. Thank you so much, Anuj. So I'll begin to speak about our work in Kenya, which is focused around 8 counties, and I'll build this in about 4 steps. One is who is responsible for what, whether it's raising money, budgeting, choosing suppliers, paying for them, and so on. Secondly, how that plays out as one continuous flow of funds, commodities, and information. Third is around what happens when that flow breaks, and it does, as you would imagine. And finally, what is being done about it? Next slide. Right, just a bit of context here. Kenyan counties are responsible for financing primary and secondary healthcare, including medical supplies, since devolution in 2013. However, the allocations only cover just 30% of the quantified supplies need. Counties also do owe the Central Medical Store, Kenya Medical Supplies Agency, which I've abbreviated as KEMSA, 58 million US dollars, and that has weakened its liquidity and contributed to low order fill rates of around 55% in the recent years. Next slide, please. So who does what? So when it comes to revenue raising, this is a shared responsibility. The national government, through the Revenue Authority, does collect taxes and other revenues, but more than 60% of that revenue already goes to servicing public debt. That is even before health sees it. Counties depend on national government transfers for about 80 to 90% of their budgets and only raise about 10% themselves. Facilities also do raise their own revenue through user fees and insurance claims. When it comes to budgeting and planning, this happens across all the levels. So at national government level, budgeting and planning is done for vertical programs such as HIV, TB, malaria, and so on, as well as tertiary care. Counties budget for health within ceilings that have been set by county treasuries, while facilities can only plan and spend their revenues when funds are confirmed in their bank accounts. As for supplier choices, KEMSA, the Central Medical Store, is a primary supplier to national and county health facilities. However, liquidity constraints and low order fill rates have forced facilities to buy from Meds, for example, a faith-based distributor, and other pre-qualified suppliers, often at higher prices. When it comes to procurement and payment, KEMSA does contract local and international suppliers, but they struggle to pay them due to some of the challenges that I've mentioned. Counties pre-qualify private suppliers and handle all the local procurement. Facilities can only pay suppliers once the expenditure request has been approved. But notice the pattern here, that at every level, the same three constraints kind of repeat. Limited revenue, ceiling driven but not need driven budgets, and payment delays. Next slide, please. Right, so this slide shows how county level movement of funds, information, and commodities jointly determine whether medicines reach health facilities. Funds, which are shown in the green arrow, move from the national treasury through county systems. Transfers to counties by the national government determine the fiscal space available for counties to finance supplies. However, county procurement volumes are often determined by budget ceilings rather than quantified facility needs. Information, which is shown by the blue arrows, moves from facilities through sub-county pharmacists to county teams and so on, and back and forth, where multiple consolidation and approval processes delay procurement. Orders then go back to KEMSA or other alternative suppliers, as the case may be, and commodities, which are shown in orange, are delivered to facilities. But the last step, which is supplier payments, when not done on time, disrupts the entire procurement cycle and does impact supplies availability. Next slide, please. And this slide now shows how health facilities with financial autonomy convert their own revenues into medicines and supplies. Once revenues reach the facility's bank account, and that is what you see on the left, health facilities managers then prioritize their needs. They cost them and obtain required approvals at county level. Only when that costed plan is approved can facilities purchase from KEMSA or any other approved supplier. Facility autonomy works only when funds arrive predictably and approvals move quickly through the county system. Next slide, please. Now that we have seen how funds, commodities, and information move at county and facility levels, this slide now shows how delays at the top cascade into stockouts. So when the national transfers arrive late, and they mostly do, they fall out of sync with already lengthy county procurement cycles. Counties already have accumulated huge pending bills, as I mentioned earlier, and must follow public finance management rules of clearing that old debt first before placing a new order. These orders then become irregular and are difficult for KEMSA to forecast, contributing to low order fill rates. Counties then consequently turn to more expensive suppliers to cover this gap, unfortunately. This creates a further chain reaction. With higher cost suppliers, that means the same limited budget buys fewer medicines and supplies, reducing volumes that reach facilities and increasing stockouts. Ultimately, each link here narrows what is available on the shelf, causing stockouts and forcing patients to pay out of pocket at private drugstores. Next slide, please. So I'll speak about a couple of reforms that the national government is undertaking to redeem some of that in the chain reaction. There has been a significant push, for example, for local manufacturing, and the target is to attain a 50% production of supplies being produced here in Kenya. I need to mention that a roadmap has now been developed by the Ministry of Health to attain this goal. Combining the second and third reform is around the introduction of a digital health superhighway through the recent social health insurance reforms. There are now platforms that track real-time claims, medicine and supplies movement, as well as strengthening quality, traceability, and oversight of supplies. Another key reform is around the facility autonomy law, which was passed in 2023, that now allows facilities to retain and reinvest their revenues in essential medicines and other service needs. Lastly, KEMSA itself is being recapitalized. The national government has allocated some funds for this to fix the problems of low order fill rates, although this is still a temporary measure. Next slide, please. Right. Now, those reforms that I've mentioned are on the supply side, but none of them are happening in a vacuum. They're happening at the exact moment the money that used to fund a huge share of this system is disappearing. Look at this. External health financing fell 57% in one fiscal year, from nearly $1 billion down to about 415 million. That is significant. Couple of drivers here. Global Fund HIV allocation is down 18%. Gavi vaccine funding is down 31%. And there were arrears owed to Gavi by the national government. And the USAID program's gap is equivalent to nearly a quarter of the entire Kenyan health budget. And it's not easy for the government to absorb this, because you see, as I mentioned earlier, more than 60% of all revenues collected is going to pay debts, public debt. There has been an on and off transition of the US-Kenya deal. Now it's back on. And service continuity following the stop work order has been a challenge, whether it's testing or prep or mentor mothers who stopped working. All this is falling through the cracks right now. Next slide, please. And so there needs to be a managed transition, and Kenya needs some coordinated tracks running in parallel and not in sequence. First of all, with KEMSA's allocated budget, this needs to be fully executed. This needs to be received by KEMSA and used to strengthen forecasting, warehousing, and last mile delivery. Second is to operationalize all these strategies developed. And we here in Kenya are really good at this. We've developed many, the Kenya AIDS Integration Strategic Framework, the TB Financing Roadmap, and others, and basically integrate all these vertical programs into primary healthcare through shared resources like staff, data, or even supply chains. A third bit is that the national government needs to meet its financial commitments to Gavi, and this is key. Strengthen KEMSA's vaccine management capacity and prepare county readiness before our 2029 deadline that has been set to ensure that counties are ready to transition to domestic financing. Finally, but not least, is expand the domestic financing through earmark taxes, bonds, and debt swaps. And this has been a discussion in this country, but not having positive response from the National Treasury. However, we can learn something from Ghana. Out of a 20% VAT that they collect, 2.5% of that is allocated and directed to a national health insurance levy. That is something that we can follow as a country. And of course, then consolidate fragmented supply chains under KEMSA. The single test across all these actions is that there should be no interruption in affordable commodities or essential services as financing responsibility shifts. The bar is that everything needs to move along as the country gradually finances its responsibility as donors continue to pull out. Next slide, please. Finally, just before I hand over back to Anuj, we just published a new brief, Beyond Budget Execution. And here we dig deeper into structural barriers that impact availability of essential medicines in Kenya. And I would like to ask all of us to have a look at it. It's available currently on our website, www.healthsystemsinsight.org. But I know one of my colleagues is going to post that link on the chat, and I'm happy for all of us to have a look into the details that I've just spoken about, put into this brief. All right, thank you very much, and over to you, Anuj.
Thank you, Eric. That was wonderful. Again, please put any question you have for Eric in the Q&A box. We can respond in the chat as well as in the panel section, or sorry, in the QA section. I see there already is one, so please continue to add there. So our next speaker, Pura Angela Ko, or Piwi, is the Country Director of Philippines at HSI. She's a physician and a health systems leader with over 15 years of experience advancing health systems and policy, financing and reforms in the Philippines and globally. Piwi was leading our facility financing work with ODI, which is fantastic. It gets really into a lot of these PFM issues, including on medicines. And it's available on our website if you haven't checked it out yet. Piwi, over to you.
Thanks, Anuj, for the kind introduction, and pleased to share about the Philippine experience of financing medicine within a fragmented and devolved health system, and what this tells us about translating public financing into reliable access. So next slide, please. To give everyone a context about the Philippines, which helps explain why access to medicine remain uneven despite our progress towards UHC. So the Philippines is a Southeast Asian country with a population of over 100 million, and we recently moved into upper middle income country status. So this transition brings increasing responsibility to finance medicines through domestic resources. We also face a double burden of disease. The health system must continue financing commodities for infectious disease. TB is a huge burden, while we also need to continue continuous outpatient access to medicines such as hypertension and diabetes. At the same time, there's actually a growing pressure to expand access to higher cost treatments, including medicines for cancer and rare diseases. The country is archipelagic and highly exposed to natural hazards. We've actually just had 9 typhoons already this year, 1 super typhoon. We've had a major earthquake and volcanic activity, and this creates very difficult delivery conditions, and resilience is an essential principle of pharmaceutical supply chain in the country. So the health system is also devolved. Local government have significant responsibilities, but their fiscal space, technical capacity, and purchasing power vary considerably. So the example on the right illustrates the range of setting that one national policy must accommodate. In Kalayaan Island, a dot somewhere to our west with just over 400 residents and 1 primary care facility, while Quezon City has roughly 3 million people and a dense mix of public and private providers. Finally, financing remains fragmented across national budgets, local government revenues, PhilHealth, private insurance, and household spending. In terms of our reforms, we're actually focusing on PhilHealth as the strategic purchaser. But even with this, even if pharmaceutical spending is actually substantial and growing, we still lack a consolidated picture of how much public finance across the different pathways and how much leverage it actually has. We do know that household out-of-pocket payment accounts for still around 41.2% of health expenditure in 2025, and then medicine actually constitute around 92% of outpatient out-of-pocket spending, compared with 37% in inpatient setting, and most pharmaceutical spending actually occur through retail drugstores rather than hospitals. This slide, next slide, maps the main financing and procurement pathways and reinforces what Anuj has actually presented earlier, that medicines are rarely financed through a single integrated cycle. So in the Philippines, we can identify at least three major pathways. At the national level, the DOH uses national budget resources to finance priority disease programs. Procurement may be undertaken centrally or through regional offices. At the local level or subnational level, provinces, cities, and municipalities combine local revenue, national transfers, PhilHealth payment, and sometimes grants. They plan and procure according to local priorities and capacities. In the meantime, we do have facilities with some autonomy, mostly national hospitals, who purchase medicines directly through using their budget, PhilHealth income, user fees, and other revenues. So each of these arrangements has their own strength and limitations. So centralized DOH procurement can consolidate larger volumes and potentially obtain better terms, but it may encounter bid failure or mismatches between centrally procured quantities and local demand. LGU and facilities are closer to the patient and local consumption patterns, but their forecasting and procurement capacity actually vary widely. So this illustrates and emphasizes that point that differing functions may be performed best at different levels. The challenge is making them operate as a coordinated system. So this fragmented procurement arrangement also poses another problem. At the national level, the Philippines has policies and market-shaping mechanisms such as HTA, the Philippine National Formulary, and medicine price regulation. However, weak demand data and uneven forecasting make it difficult to translate these policies into accurate budgets, consolidated demands, and credible purchasing plans, resulting in erratic supply in the public sector. So fragmented and uncertain orders can actually reduce supplier interest and weaken public sector bargaining power. When public pathways do not provide medicines reliably, so patient returns to the private sector and pay out of pocket. Recently, PhilHealth has actually created the Gamot or Medicine Outpatient Benefit Package, which offers an important opportunity to reduce this burden by using PhilHealth purchasing to purchase directly from those retail drugstores. Its success, however, will depend not only on ensuring leverage and obtaining better value and reliable supply, but also on ensuring that patients have accessible dispensing points, especially in municipalities where there's no retail pharmacy market or it's thin or absent. So if not, it's going to risk adding fragmentation to the pathway and further weaken the leverage of public purchasing. So next slide, please. Similar to what Eric was also saying, the problem is that each failure at each stage reinforces one another. So it often begins with uncoordinated financing. So national, local, and PhilHealth funds follow different timelines and rules. Budget uncertainty weakens forecasting, while forecasting capacity varies widely. This contributes to fragmented procurement. The DOH, LGUs, facilities, and other public purchasers may procure separately. Order remains small, and no actor has complete visibility over what is being purchased, what is available, or where gaps remain, and who is actually accountable for what. So PFM constraints adds another layer. So multiple approval and compliance requirement can delay purchasing, while more flexible mechanisms such as framework agreements and multi-year arrangements and digital procurements remain underused. Testing, storage requirements, multiple handoffs, geography, and disaster exposure can introduce further delay during delivery. And overall, each problem again contributes to the other. So a delayed budget leads to delayed procurement. Delayed procurement may result in bid failure. Bid failure leads to emergency purchasing, which often means smaller quantities, higher prices, or medicines arriving too late. Over time, the workaround becomes part of the normal system. I think I also want to link this back in terms of the CGD framework, wherein access is the outcome of the full pathway. So this slide shows that weakness accumulates across planning, sourcing, delivery, and the final burden falls on the patient through stockout, delayed treatment, or higher out-of-pocket spending. And this brings us back to the two cross-cutting pillars of the framework, so governance and data and analytics, because responsibility is dispersed usually throughout the system. No single actor necessarily has the authority, information, or incentive to resolve the entire cascade. So governance is then crucial to clarify responsibilities and accountability. Shared data is needed to connect health needs and consumption with budget, procurement, stock, prices, and patient access. So these functions need to be strengthened to allow the pathway to operate as a system. So next slide, please. So the Philippines has actually had 3 decades already of trying to reform medicine access and medicine financing. The UHE law is just another attempt in terms of improving financing of medicines in the Philippines. The immediate task on hand is actually trying to connect them and make them function more coherently. So the first area is for in terms of strategic market shaping. So we actually have the formulary already. We have HTA, we have price negotiation and reference pricing, but these need to be supported by faster decisions, stronger market intelligence, and clear links to budgeting and procurement. Decisions about value have limited effect if they do not shape what is financed and purchased. So second is ensuring that PhilHealth is coherent in terms of expanding its purchasing role and ensuring that this links to PFM processes. The third is ensuring that we are trying to implement functional pool procurement. The fourth is in terms of trying to fix and make our PFM system more flexible and accountable. And fifth is ensuring that we're able to use usable and connected digital systems. So next slide, please. So the main lesson from the Philippines is that medicine access depends not simply on the amount of funding available, but on how well financing, purchasing, and delivery arrangements are aligned. So financing must be coordinated so that procurement can work. Second, agree in terms of the need to move beyond the centralization versus decentralization debate and ensure that we're actually giving the functions to where it works best. And third, a reform only matters when they are operationalized as part of the coherent system. So improving access is not only about spending more, it's actually about making every financing and procurement decision contribute to reliable, affordable, and equitable delivery. And with this, handing it over to Catherine for the panel.
Thanks very much, Pee-wee. We're seeing some great questions coming through in the chat, so I'm really interested and excited to start the panel. But just before we get there, I want to hand over to Ed Llewellyn to give a few comments. He's a senior commodities and supply chain specialist who leads the development and implementation of the Global Financing Facilities, Commodities and Supply Chain Strengthening Strategy. And so I'm excited to hear a few comments from him on the global multilateral partner perspective. Ed, over to you.
Thanks, Catherine. Just a little background. I lead on commodities supply chain at the Global Financing Facility, which is a partnership hosted at the World Bank focused on improving health and nutrition outcomes for women, children, and adolescents. And the way we work is that we raise funds and then we co-finance World Bank operations, which means that the vast majority of our funding goes on budget to partner countries. We're part of the broader World Bank group, aiming to target delivery of affordable health services to 1.5 billion people by 2030. And timely and reliable access to commodities is a key part of that. I think I want to start just by saying that against this context of reduced external assistance, a part of the North Star of our strategy is that countries need to increasingly partner and integrate with the private sector. And so we think about access, which you saw on the framework Catherine presented earlier, as being a kind of an aggregate property of a mixed system of channels in a country, not just the sort of the exclusive domain of the public sector. And I mention that now because I will hopefully have time to come back to that at the end. I think the key point that's come out of a lot of the discussion so far is what the sources and what the impacts are of volatility within the financing and supply chain kind of complex within the public sector. I want to add that volatility in one channel, like the public sector, has an impact on the private sector and vice versa. And sometimes that volatility has been has kind of prevented or mitigated against increased private sector participation in the mixed system. And for the reasons I said about declining funding, we do think that that's critical. So this issue of volatility is kind of a key challenge to resolve. As we start to look at health, the work that CGD have been hosting that links health financing to supply chain, I think we've discovered that these two sort of professional domains don't always talk to one another as well as they could. I've found it helpful in trying to understand. I come from the supply chain background. I found it helpful in trying to find the relevance of our work in health financing to really split health financing in perhaps an unconventional way. But I think of it as in terms of the health financing broad label as being sort of the policy environment in which the supply chain needs to operate. And some of the work that has happened within the Nexus work is looking at this issue of centralization and decentralization. And I think a conclusion of my own is that there's no real sort of one size fits all. Actually, the discussion around which functions to centralize or decentralize is really critically dependent on the overriding sort of enabling environment or policy environment set by health financing and how services and products are paid for. I think it's then important to separate the commodity financing from supply chain financing, and we often tend to kind of conflate them. There's clear country examples where, and Madagascar is one, where in a recent study that we did looking at mixed systems, we found that while there was sometimes sufficient financing available for commodities, and commodities were in good supply at certain levels of the system, the last mile was missing out because there hadn't been sufficient mobilization of supply chain financing, especially post the shuttering of USAID. And I think this points to a vulnerability, which is not just about adequacy of financing, it's also about knowledge or understanding of where financing needs to be deployed through the system to achieve access. In this case, and I think this is common, if countries are not aware or not able to provide evidence for what the costs of distribution and what the costs of that supply chain financing element are in terms of their negotiations with Treasury for budget release, then they're really sort of vulnerable to having underfinanced supply chains, which means that even if you manage to fix the commodity financing issue, products ultimately won't get to the last mile. I think another key thing coming out of some of the presentations we've heard is the distinction between adequacy and timeliness, or liquidity was the word that Eric I noticed used. Often when we talk in the commodity financing realm, we're really looking at adequacy. And the gaps are often so large that we're making incremental improvements in the availability to cover needs. But once you start to get into country systems, I think this issue of liquidity becomes key. So it's about having financing available on time, not just enough financing overall. And that points to the critical link, I think, that joins health financing as a broad topic with supply chain, which is the supply chain plan. And I think a key distinction in sort of the way in which we look at these as different professional disciplines is that in the supply chain, this liquidity element is key. And so supply chain planning, it is and should be a very frequent and iterative discipline conducted within the system. It's not as straightforward as achieving adequacy through health financing, revenue raising, for example. And it's also a more operational and a more iterative discipline than figuring out kind of new and innovative ways in which to finance the system by kind of rewiring the ways in which funding flows. Zambia is a country example where they've really kind of taken this to heart. A key priority of their health system strengthening agenda is achieving interoperability between the supply chain planning systems and Ministry of Treasury or Ministry of Finance systems. And they're viewing this ability to get visibility to the supply chain and analyze on an iterative basis as being like a key sovereign asset. I think continuing on the theme of the criticality of supply planning, Ethiopia, recent policy changes in Ethiopia point to the importance of getting away from supply plans being aspirational or even potentially used as an advocacy tool, because they're implementing a system called CDSS, Committed Demand and Supply System, which really means that even as health facilities, so the lowest level of the supply chain of the health pyramid, are coming up with their quantifications and forecasts, they're trimming those forecasts deliberately by available budget at the point of creating them. And I think that's key because what it will do is it will mean that as supply planes are aggregated, they really become the basis for operational planning, and they can also ultimately become the basis for KPIs measurement and provide a more robust basis for accountability than supply plans that started out as being sort of aspirational or for advocacy. What I mean by that is that a supply plan that's generated by consensus and is already constrained at the point where it becomes disseminated for broad use. Against that, you can say, how timely was the timeliness of Treasury funds release in line with the supply plan? And if not, let's go there to try and figure out what the root cause is and ultimately, hold that function accountable for their part in the overall supply chain. If the funding was available, but procurements were delayed for whatever reason, then again, that points to a discrete function within the system where we can look for improvements because we can detect if procurements were not making commodities available in line with the supply plan as the basis for performance. And then ultimately, the supply plan can be decomposed into a distribution plan. And again, you can then look at the entities responsible for the actual last mile distribution and look at whether they were adequately financed to hit their KPIs based on the plan. And so this idea of the supply plan really being a robust basis for coordinated action feeds into transparency and accountability of different functions and looking to invest where those functions are under-resourced. If we're aiming for transparency and accountability, then it's equally important to make sure that as we invest in the sort of the technical interoperability of these systems, we're also investing in governance structures that will be able to interrogate performance against these plans. And that's not straightforward. And it needs to be multidisciplinary. I think, again, the presentations have highlighted the links that exist between different functions that are not necessarily within sort of vertical organizational structure silos that typically exist in organization structures. And so setting up the governance piece of this is important. It needs to think carefully about the structures and the stakeholder set that are involved. It needs to be precise as to the decision rights of different groups that are consuming consensus information. And there needs to be a common process and cadence to that decision making that aligns with the iteration of the supply plan and supports coordinated action. And I think it was Eric as well that was saying that mismatches in the processes and the sort of the cadence and time base of some of these processes is as much an issue as adequacy of financing. So some takeaways that I take on board, but I think others in the kind of the financing space could as well. I think we need to aim for simplicity and defragmentation. Eric's examples gave very complicated wiring diagrams, and everything we can do to simplify, I think we should. I mentioned at the top that the GFF co-finances against World Bank operations. I think anything we can do to defragment funding flows, bring them on budget, or at minimum, make sure that between Treasury and supply chain organizations, it's possible to see the full range of resources and have decision rights over how those are allocated is a positive move. I think we need to invest more in this critical capability of supply planning, but also be real as to what a supply plan is intended to be, and how it should coordinate action. And then ultimately, I think we need to invest in leadership skills that will be able to make this multi-stakeholder and consensus approach work. The supply chain leader of the future is no longer a logistics manager. They need to have skills across. They need to have a combination of skills across leadership, cooperation. They need to be able to manage contracts. They need to be able to work across the public and the private sector, and be able to have skills like negotiation, prioritization, have financial literacy as well as technical literacy, etc. So there's a different kind of skill set emerging as being critical from potentially the sort of the older model of managing just the logistics operations of a medical store. And the Supply Chain Leaders Forum that myself and others in across Global Fund, Gates, Gavi, the USG and others are really looking to try and achieve some sort of some peer learning platforms through having created the Supply Chain Leaders Forum and a platform for advocacy as well. So in closing, I think investing in these kind of capabilities and these leadership capabilities that I mentioned last is as much about improving the public sector, but it also will create a set of skills for managing across the whole mixed system. And if we're able to get the public system to be more predictable and less volatile, it will have less impact on volatility in the private sector, and it will enable the public sector to be a better customer of the private sector, both in supply markets in terms of the procurement activity, as well as in exploring integration with the private sector as a set of new and alternative distribution channels. Ultimately, both of those interfaces will help to address the overall pressure of downward donor funding, and the need to improve access by whatever channel is most appropriate and patient-centric to the needs of the population. So this kind of country-owned, integrated, and sustainable future is what we're looking to drive towards as the GFF through our co-financing model. I'm going to put a link in the chat to a paper that was developed by the Funders Forum of the different organizations I just mentioned, which tries to expand a little bit on some of the themes I've talked about today. Thank you.
Thanks very much, Ed. Great. So now we have a little bit of time for a panel discussion, and I'm seeing lots of great questions in the chat, some of which have been answered. I think there's a lot around the questions around the donor transition, and I want to come to that in just a moment. But first, I was seeing quite a lot of questions around the central medical score model. We saw that in Eric's presentation about Kenya that there seemed to be definitely some issues with the model, with he mentioned a 57% fill rate. So I guess a slightly provocative question is, do you think the issue is the central medical store model itself, or is it that we're asking this to do the central medical store to perform too many functions? So maybe, Eric, I could first turn to you, and then I know Ed has some opinions on the topic.
Right, thanks. All right, I do not think that the problem is the central medical store concept, as it were. I think it's that we've loaded too many jobs onto one agency, buying, storing, delivering. But in Kenya, I think it's also become like a lending bank, which lends money to counties who pay late or don't pay at all. And that last role of kind of lending to counties is what kind of breaks all the other roles. Because a logistics agency shouldn't be an unsecured lender to subnational and national governments. So one of the things is that there is need to fix that bit of payment. Perhaps coming up with some interesting ideas here, like the Treasury settling bills directly instead of the medical store extending its own credit to counties and the national government. There could be an opportunity. Kenya is currently rolling out a Treasury single account for all 47 counties, and that is beginning July of this year, which consolidates county cash management under the central bank. Perhaps this is the kind of reform that could allow Treasury to settle some of these bills. Alternatively, to enforce the public finance management provisions that require bills be paid once they have been committed to. So that aspect of the fiscal indiscipline is what has been a big challenge for KEMSA. But I don't think the central medical store concept in itself is an issue. I think it is just that last bit of where counties and national government have not been able to pay up on time, and that has constrained KEMSA's ability to perform its role effectively. Thanks.
Ed, I'm going to turn to you on that same question.
Yeah, I think I would agree with Eric. I think this issue of kind of fiscal discipline needs to be highlighted. It's one thing to say that, though. It's another thing to kind of actually affect that change. And so I think, investing in digital systems that can track transaction level information and then drive analytics off transactions, as opposed to a kind of a survey methodology, which is common, will be the way in which we start to have the tools in place to achieve that kind of fiscal discipline. I said, as I was talking earlier, I think the supply plan that is actually a consensus plan for coordination and the basis for accountability is really the sort of the North Star of what we should be aiming for in terms of digitizing transactions, analyzing them, bringing together different parties to create a consensus plan, and then holding that as almost like a system of record for accountability, rather than a kind of an advocacy tool.
Thanks. And you mentioned fiscal discipline, so maybe I can think a little bit about the public financial management. Pee-wee, I wanted to turn to you. Maybe you could speak a little bit about some practical public financial management reforms that countries have successfully implemented.
I guess we shouldn't look at PFM as a constraint, but something that needs to be enhanced, because essentially it's what also will ensure that we're able to actually get value for money in terms of this. And I think even in terms of this, we can look at it in terms of where in the system we're actually trying to fix procurement. If it's at the facility level, there needs to be a bit more flexibility, especially since they don't have as much capacity in terms of PFM systems. I think we've already alluded to the need to digitize systems. While I was actually doing some of the research for the financing supply sheet for the Philippines, I was asking my husband how's it like in the public hospital where he works, and he was telling me that there they actually print out the paper. They have a large table where they're putting the paper and trying to really sort through the procurement process. So there's a need to actually do that digitally. There's opportunities to be able to do that, and that will actually help in terms of the workflow of many of the different agents in the various countries. So that's one, but also just if we're trying to implement some efficiency measures, I know Doge is probably not a good term in our sector, but I think there are things that we can actually try to sort of cut back, really just get back to the principles in terms of what we're trying to do with PFM. So maybe that's something in terms of processes that we can actually apply.
And Anuj, from your work looking across the various countries you did with HSI, do you have any thoughts on practical PFM reforms that countries have successfully implemented that other countries could learn from, perhaps?
Yes, thanks. I mean, this is one of the things that emerged from the case studies and one of the reasons why the updated framework now embeds PFM explicitly across all 10 functions, because it really influences how quickly and effectively resources can move through the system across all those different cycles, from planning to budget execution to cash management, supplier payment. The big bottlenecks that came out were kind of this, yes, there was issues around funding, but really a lot of it was delayed and rigid budget execution, delayed supply payments and arrears that we saw in Kenya with the CMS system. And so practical reforms, there's lots of details that we're going to get into. And then our colleague in the working group, Jenny Assman at UNICEF, is going to be writing a paper on this. And we've kind of gone over some of the initial thoughts of it. More predictable budget releases, better alignment of procurement planning with budgeting, with what Ed was talking about earlier about coordination between different actors, faster supplier payments. One thing that we didn't touch as much on in this presentation, but Peewee does quite a lot in our work with ODIs, is the idea of facility autonomy. But how does that happen? When is it most appropriate with accountability mechanisms as well as capacity building at those lower levels, especially when you're talking about primary healthcare facilities in remote and rural areas? And I think Peewee's point, especially about digitalization, there's a lot there that can improve processes, but there also are kind of infrastructure and structural issues that and regulatory issues that kind of prevent that digital inclusion into some of these processes at scale. We see it's at smaller levels at different districts and counties, but what does that look like at scale? And how can governments align that with what their actual needs are rather than just digitizing because it's a new fancy tool? So yeah, let me stop there.
Thanks, Anuj. I think a lot of the questions in the chat we're seeing are really about what the future of this supply chain financing is going to look like in this current donor transition period we're in. So I think, firstly, I want to maybe turn to all of you. I think there's questions for both what it means for countries and then what it means for donors. So maybe we'll start with what it means for countries. But if we look across the different functions in the framework, where do each of you see the greatest opportunities for relatively quick improvements, sort of low-hanging fruit? There are things we should think about and then how we sequence the reforms. And this links to a question in the chat. I saw that, from your perspective, which financing forms have the greatest potential for improving access? Just because it's the order I see them on my screen, maybe I'll turn to Ed first and then Peewee, Eric, and Anuj.
Yeah, I mean, I think what somebody said, and forgive me, I forget exactly whom, but it may have been Eric's presentation again. I think I don't think there's an easy sequencing here. I think there's a lot of activity that needs to happen in parallel. And that is a feature ultimately of, a lot of the net funding to supply chains and to commodities has kind of to a greater or lesser extent worked around country systems for a long time. And so we're now paying back the deficit of that. So I'm not sure that there's a kind of a sequence that I would recommend. I also think that the investments need to be owned by countries and dictated by country context. And so I'm sort of reluctant to venture a sequence. I think it needs to be country-led. Over.
Peewee, same question to you.
To Ed's point, there's a lot happening in the country, and I think I was rushing through it in my last part. But essentially, where we are is probably the right starting point. We sort of have a pooled procurement mechanism, but we haven't made it work yet. And I think similarly, it's the same problems that Eric and Ed were also saying in terms of liquidity, in terms of this and that. So I think, especially in such a fragmented setting in the Philippines, we have the opportunity to make it work. And then I know that our SHI is actually doing a relatively good job in terms of revenue generation. But to Ed's point that we have to bring it back in budget, it's probably something that we have to experiment and ensure that in terms of the public procurement mechanism, we're actually trying to strengthen it and enforce it. If purchasing through retail, I think there are different principles that we must uphold to ensure leverage. So that is something that we have to iterate on a bit. It's the current design probably doesn't do that yet. So it's in terms of actually trying to make these systems work, where I think the short-term opportunities are. We're actually there. The Global Fund also has a transition plans for the Philippines, since still a lot of commodities for TB are still procured by the Global Fund. So I think similarly, this is an opportune time to actually strengthen systems and transition what has been previously donor funded in the Philippines as well.
Anuj, would you like to come in on this?
Nothing major to add. I agree in the sense that I don't think even across the 4 case studies and the discussions we've had in the working group, there is some kind of sequencing that works well. I do think that, one thing that we haven't mentioned as much, but plays a large role is like political economy of some of these discussions. When we talk about governance and institutional arrangements and different actors in the system, whether it's the Ministry of Finance, Ministry of Health, supply chain agencies, private sector, there is quite a complicated and kind of intransigent set of foundations in a lot of countries. So trying to change those and go in and say, yes, we can go in and have everyone work together on day one is probably not realistic. But I think it really depends on the countries and the ongoing reforms that they're pursuing and what can be tweaked within some of those. And so, for example, I think trying to improve just the kind of mindset around financing and PFM and supply chain and where the connections are and how the bottlenecks are stemming from some of those connections within the functions is just a good starting point to kind of get those ideas together and then working towards, one of the big things that, again, like I said, were the governance issues. So who does what and where and using what data. So starting with kind of just laying that out and then pursuing what's practically feasible in a lot of these countries. And maybe once you get a couple wins, there's kind of momentum that's built and you can pursue some of those, more touchy issues. Over.
And just on that, Anuj, do you have any comments on what sort of governance arrangements seem to be working best in reducing fragmentation and improving accountability?
I think some of this is kind of in the centralization and decentralization paper that I worked on with Sophie, where, again, not to say something, but it really depends on the country and the capacities and the governance arrangements that are in those countries. But for example, when Eric was talking a little bit earlier about issues with KEMSA, you kind of think about that CMS model and what Tanzania has done around it. So they didn't change that they have a CMS model, but they created a Jazia Prime vendor model where there's a pre-approved set of suppliers that facilities can order from. They, were able to set up financial and supply tracking systems that then, and also capacity at the lowest level, bank accounts for facilities to receive direct facility financing, and then be able to order from alternative suppliers, pre-approved alternative suppliers when there's stockouts. So I think there's things you can do even around existing systems, but the governance, it really depends on the country. For example, in Indonesia, you have BPJS, which leads JKN, the National Health Insurance Agency, and you have the MOH, and there is a lot of real strong governance issues between them, and they're not going to be solved very easily. So trying to figure out what's reasonable within like some key bottlenecks could be a starting point. But yeah, more in a couple of these papers that are coming out. Cheryl Cashin's paper from R4D also goes into a lot of detail on this, which is great.
Thanks. I'm aware we're getting close to the end of time, but I definitely wanted to save a bit of time to think again about the donor transition and what the role should be for donors going forward. And I see a question in the chat about, what are the roles of the major global health institutions in procurement and access going forward at the country level? Eric, maybe I could start with you, but I'm interested to hear from all the panel. Yeah, what should the roles be? Are there any particular risks that you're worried about as countries transition? Are there particular solutions we could think about for how donors can transition out in the least in the least disruptive way.
All right. Thanks. I think for me, the biggest risks are kind of disorganized um, leaving of donors. We did see what happened last year with the stop work order. That donor transition was a little disorganized, and donor monies are basically running out faster than countries can build the funding capacity to replace it. And countries could lose a lot, not just medicines, but a lot of the processes that donors have been supporting. And in this case, we talk about forecasting or procurement or quality assurance systems and so on. And I think there needs to be a clear strategy, and Kenya has done a good job in terms of putting these documents, the transition documents, in place. There are all these transition plans that have been costed, and now there is another plan, a 5-year Kenya-US agreement that kind of creates a transition plan, but that window must be used to expand domestic financing. And there is a provision in that where the country needs to put in funds to begin to take over some of the functions that the donors are doing, but also speed up the integration of donor-supported programs into the national systems. I think that is what needs to be done so that we ensure that there is a kind of organized transition and not wait until perhaps something like this happens to countries again. Thanks.
Thanks very much, Eric. Pee-wee, same question to you.
I think it's still in terms of system strengthening. So I think first kudos to the working group in terms of the work you're doing in terms of trying to unpack this. I think many of this actually needs to be further operationalized in countries. And right now, when many systems continue to be weak, it needs to be strengthened. So these principles need to be applied and it needs to be disseminated. And I think there's still a lot of knowledge work, a lot of capacity building, and a lot of maybe still thinking of the innovation in terms of what we need to do better, need to do more effectively. So I think there's still a lot to do in terms of that.
Thanks very much. Anuj, maybe I could come to you now.
Sure. I don't think I have too much here. The one thing I would say is, yes, this has to be more of a transition and gradual rather than immediate, what happened last year. I think also we haven't really got into this, but there are, more regional opportunities to try to have kind of pool procurement done regionally rather than at the global level, or how can lessons from global pool procurement be passed down to regional procurement? So I think those discussions are live and they're happening, but it'd be good to see that more formalized and then actually operationalized more in the next few years.
And last but not least, Ed, any final comments from you on this topic as someone sitting in that more donor role?
Thanks. Yeah, so I'll try not to repeat some of the takeaways I mentioned at the end, but I will say that as the GFF, as part of our strategy, we've launched this new initiative called SCAP. So that stands for Sustainable Commodities Access Program. And I hope that it embodies, some of the principles I mentioned earlier. So SCAP it's a commodity financing incentive program or initiative. It provides additional resources. So basically, it mobilizes resources from a range of funders that are interested in supporting the goals of the GFF around women's and children's health. It kind of consolidates those and defragments and puts them alongside bank projects, which means that funding for commodities is going on budget. It includes quite a demanding incentive for generation of domestic resource mobilization, because as others have said just before me, that ultimately is where we need to be headed. We can't afford to continue to sort of fully subsidize commodities and then cliff edge that support. And it also bundles with the commodity support funding to support health system strengthening, and specific monies to support with the distribution costs. So that supply chain financing element that I mentioned earlier, as well as the commodity financing element, so that you don't end up with, commodities but no way of getting them to the last mile. And it also incentivizes funding against a kind of a basket of commodities. So we're not picking individual commodities or individual types of service delivery to fund, because we've seen the risk that actually crowds out local and regional manufacturing of those products at a smaller scale, which would be non-competitive if you have donor support to individual products. So I buy into the local and regional manufacturing agenda, and I think there are specific things we can do to not sort of cause harm to that as donors. Over.
Thanks so much. I'm aware we're coming to time, so I just wanted to thank all the panelists for their excellent comments and contributions. There's so much more that could be said on this, and I think it's a really fascinating conversation. It's great to see that the topic seems to resonate with everyone. It's clear that, thinking about the financing of supply chains is crucial, and especially in this era of transitions. So please do keep in touch with us. On the screen are some QR codes for more information on both the work that CGD and HSI are doing on this. Yeah, I think it's clear that everyone has something to bring, and that no one silo can solve this problem. It can't just be health financing, it can't just be supply chains. Ed talks about we can't just think about financing commodities, but we have to think about actually financing of the supply chain. That might be something that health financing experts miss, and I'm sure there's vice versa issues. So it's really great to see this group come together, to see all the engagement with it. And yeah, please do keep in touch, as we hope we can put out more work on this. And with that, I'll hand back to Nathan just for a final close.
Thank you very much, Catherine. Thank you to all our panelists. This was such a rich webinar. Thank you for all the great questions. This was really, really great. I know we're technically over, but if you hang on just one more minute, I would just like to thank everyone for joining our whole 4-part webinar series. This has been such a great learning opportunity for us, and a great opportunity for us to reflect on 8 years of work. If you missed our previous ones, I really do hope you'll see all 4 of these topics together. In the first webinar that we started, we saw the power of giving better information on some very basic things, basic input data on resources that district managers have under their authority, and how that can lead to more strategic allocation, the very first step to finding more value in the system. We moved on to larger levels, like coherence across multiple purchasing programs, and how improving that can also increase efficiency and do more for primary healthcare. We saw in the third webinar how much efficiency there is to be gained in looking at fund flows, and we heard how that affects medicines and supplies today, from budgeting processes from national to district level, and also what goes on at the facility level. So much of what we heard today were echoes that focused on medicines and supplies that relate to larger issues in the system. And we have found and work with our country partners that each one of these key priorities is quite valuable on its own. Sometimes the political economy is such that you can only work on one or two, but we believe that the ideal scenario, where the political economy would allow an opportunity to do so, the ideal scenario would really be to work on all 4 of these together. Of course, in tandem with advocacy for more funding for health, but I find in many sectors that showing that you are improving efficiency is often one of the best ways of making advocacy for more money more effective. So we hope you will look at all these together. We're happy to answer any questions about them. We are also sharing a great deal of resources related to all of these. My colleague Elaine has put the link to our website. The resources from today will be added there soon. So there are the slides, the recordings on a YouTube channel, and many related papers, learning products, publications related to all 4 of these topics are there for you. And we're available offline to answer any questions that you may all have. So that concludes our time today. I want to thank sincerely the Center for Global Development for co-hosting with us today. Thank you, as always, to the Gates Foundation for the support for all of this work. And most importantly, thank you to all of you for joining, whether it was only today or for the whole series. It's really been a privilege to be able to connect with really hundreds of people and hundreds of organizations across these series. We hope it has done a little bit of good in a very, very trying time for healthcare around the world. Thank you very much and have a good night.